everyone, this is Kendra Cundiff with my episodic note presentation of nausea, vomiting, dizziness, and diaphoresis. She is a 42-year-old female who presents in the clinic with a chief complaint of sudden attacks of nausea, vomiting, dizziness, and diaphoresis. The episodes began approximately 9 months ago and occur at random with 10 attacks. The episodes usually last about an hour and start with right ear fullness and ringing, then progress to debilitating dizziness, nausea, vomiting, and diaphoresis. She states that the attacks happen at random times and that she is unable to function when she's having an attack. Or worse, and she states that she's often exhausted for 1 to 2 days after an attack. Over the last 2 months, JH has noticed continued ringing and fullness of the right ear, along with decreased hearing in the right ear. Denies fever, chills, or trauma to the head or ear, or headache. Current medical conditions. This patient has hypothyroid. She was diagnosed with in 2005, which causes a rash. Current medications are multivitamins, 1 tab daily, and levothyroxine, 125 micrograms daily. Past surgeries, a C-section in 2006. Immunizations, influenza October 5th, 2016, Tdap October 2014. Gynecologic and obstetric, she is G1, P1, and is currently perimenopausal starting around 2014. Family history, JH is the only child. Her mother is living at age 73 with a history of Meniere's disease, diagnosed at age 48, and hypertension. Her father has not been in the picture. She believes he's about 78 years old, but does not know any past medical history for him. Patient denies alcohol, tobacco, or illicit drug use. Review systems. General denies fevers or chills. Cardiac is unremarkable. Respiratory is unremarkable. Head, ears, nose, and throat. Intermittent right ear fullness and tinnitus. Denied decreased hearing in the right ear. Patient denies pain. Neurointermittent dizziness is rotational with associated nausea, vomiting, and diaphoresis. Blood pressure 122/88, pulse of 68, respiratory rate of 18, temperature is 97.8 Fahrenheit. The patient is 5'7" and weighs 155 pounds with a BMI 24.3. Physical exam. General, well nourished, appears no acute distress, alert and oriented times 3. Cephalic atraumatic. TMs are good with good cone of light bilaterally, no redness or bulging, rubber localized to left ear, Rhine positive, air conduction greater than bone conduction in the right ear, air conduction equal to bone conduction in left ear. No sinus tenderness, septum midline, nasal mucosa pink, pharynx without exudate, trachea, midline, thyroid palpable, normal shape and size, no masses, no cervical lymphadenopathy. Neuro, pupils equal round and reactive to light, face symmetrical with sensation intact. Tongue is midline, cranial nerve 1 not tested, cranial nerve 2 through 7 and 9 through 12 intact. Cranial nerve 8 abnormal, whisper test in the right ear, left ear whisper test intact. 5 out of 5 throughout. Finger to nose and heel to shin test intact bilaterally. Normal gait, normal balance. Reflexes 2+ throughout. Rhythm, normal S1 and S2, no JVD, murmurs, gallops, or rubs. Unlabored respirations, chest expansion symmetrical, lungs cleared to auscultation bilaterally. The diagnosis for this patient after reviewing the history, present illness, the history, and the physical exam is suspected Meniere's disease. However, there's some criteria that's not met in order to make a final diagnosis, which I will discuss in just a few minutes. So defining the disease, Meniere's is an idiopathic disorder of the inner ear. It results in spontaneous and recurring attacks of vertigo that may have fluctuating hearing loss. Cause of Meniere's is unknown. However, there is usually a disruption in normal homeostasis of the inner ear. There are some possible contributing factors that include genetics, inflammatory, immunologic, inner ear autoimmune process, viral infection, syphilis, Lyme disease, hypothyroidism, trauma, vasculopathy, endolymphic sac dilation and ischemia, and metabolic fluctuation of electrolytes. Disease, endolymphic hydrops, which is distortion of the membranous labyrinth of the inner ear. And also there's thought to be dysfunction of the cellular channels along with dysregulation of the ionic composition of the endolymph. And the degeneration of the inner ear due to multiple insults results in hearing impairment and vertigo. Some risk factors for Meniere's include family history of Meniere's. If a first-degree relative has a diagnosis of Meniere's, there's about a 50% chance that the patient could have Meniere's as well. There's some possible triggers for attacks of Meniere's, which include barometric pressure change, allergy attacks, stress, hormonal changes, sleep deprivation, diet changes, and excessive perspiration followed by large volume fluid replacement. Among various ages and genders is usually seen in age 30 to 60, females greater than males, and the incidence is about 190 per 100,000 people. Common symptoms related to Meniere's, there's the classic triad, which includes vertigo with spontaneous onset lasting usually between 20 minutes to 3 hours, hearing loss that's usually unilateral and affects low frequency sounds, and also ipsilateral tinnitus. Patient may also have symptoms related to the vertigo, such as the nausea, vomiting, and diaphoresis, and also may be asymptomatic between attacks. According to Essentials Evidence Plus, the American Academy of Otolaryngology head and neck surgery requires for have a definite diagnosis of Meniere's. And the first one is at least 2 spontaneous episodes of rotational vertigo lasting for at least 20 minutes. The second one is the audiometrically confirmed sensorineural hearing loss. And so this is the reason why I'm unable to diagnose my patient with Meniere's today until she's able to follow up with audiology for her hearing test. The third one is tinnitus or oral fullness during episodes. And the fourth is exclusion of all other possible causes, which may also be another reason. We'll discuss differentials, why I'm not able to diagnose my patient with Meniere's today. Differential diagnosis include migraine. A migraine can mimic early Meniere's, but usually the patient has a headache during or after the episode, dizziness along with their headache, and hearing loss is usually mild or stable, not progressive. Benign paroxysmal positional vertigo is a differential as well. This is episodic vertigo that usually only lasts a few seconds to minutes and is usually elicited by head movement. It's not associated with hearing loss, tinnitus, or ear fullness. Acoustic neuroma is unilateral high-frequency hearing loss, and the patient usually experiences more of an imbalance than a true vertigo. But according to treatment guidelines and Dynamed, plus it must be ruled out with an MRI in all patients with suspected Meniere's disease. So this is another thing that I must rule out before I'm able to diagnose my patient with Meniere's. The last one is vestibular neuronitis or labyrinthitis. This results in spontaneous vertigo. It feels unsteady for days, and usually the initial attack is a long episode followed by shorter episodes. Management plan. Diagnostics for this patient, I'd like to get an MRI of the brain and acoustic meatus to rule out retrotrochlear disorders. Also, the patient's going to need a check of her TSH. She does have hypothyroidism, so it's important to check to make sure that her thyroid levels are within normal limits and are not the cause of any of her symptoms. Medications. Since I do not have the diagnosis of Meniere's, I'm going to treat my patients symptomatically. Dynamed Plus listed beta-histine as a good choice to help prevent vertigo. It may improve vertigo symptoms in patients with Meniere's. The dose is 60 milligram, 1 tablet 3 times a day for 30 days. And I'm also going to prescribe compazine for symptomatic episodes where the patient has nausea and vomiting. compazine 25 milligrams PO Q4 hours as needed for nausea and vomiting. Management plan continued. The patient's going to need a referral to the audiologist in order to make the final diagnosis of Meniere's. I'm going to have the patient follow up with me in 2 to 4 weeks for reevaluation of symptoms and medications, and also to review the results of the lab work, the MRI, and the audiology appointment. Patient will be instructed to return sooner for any ear pain, ear drainage, severe headache, or sudden deafness. Patient should also be educated on the medications to take them as directed. The beta-histine has very few side effects, but usually they're just gastric irritation. Compazine should be administered with milk or food to minimize GI distress and may cause dizziness, drowsiness, dry mouth, blurred vision, constipation, and urinary retention. Patients should be instructed to use the compazine only when they are having symptoms of nausea and vomiting and not on a regular basis. For Meniere's, it's really important for patients to consume a low-sodium diet. This has been shown to improve vertigo. Patients should restrict their daily sodium intake to 1 to 2 grams a day. They should also restrict caffeine and alcohol consumption. Patients should also be educated on vestibular rehabilitation, such as the Brandt-Dardoff exercises and the Cawthorne-Cooksey exercises. The Brandt-Dardoff moves the patient from sitting to laying on one side, then back to sitting and laying on the other side. And the Cooksey exercises include exercises moving the eyes, moving the head, and moving the body. These are thought to help relieve symptoms of vertigo. Patients should also be educated on safety, not to drive or to pull over if they start to have an attack, and they should wait until after the attack passes and they're feeling better in order activities. Since Meniere's is an idiopathic disorder with strong inheritance pattern, there's no real prevention methods for this disease. Meniere's treatment is to prevent attacks and symptoms that are often debilitating and try to prevent further hearing loss. Patients can help prevent attacks through stress relief using regular diet, sleep, and exercises, along with regular prescribed medications. The treatment guidelines listed in Dynamed Plus and Essentials Evidence Plus both follow pretty similar paths. Both of them discuss the patient consuming a low-sodium diet and avoiding caffeine and alcohol, and the vestibular rehabilitation that we just talked about. Beta-histine was listed in Dynamed Plus as a good option for treating symptomatic vertigo associated with Meniere's disease. Also, a study by doses of beta-histine around 288 to 480 milligrams a day was effective in treating patients with severe Meniere's who did not respond to lower doses. Participants in the study also had very few mild side effects, complaints, fatigue, and altered taste, none of which were severe enough to discontinue the higher dose. So beta-histine is a good choice for patients with Meniere's because the practitioner will be able to dose in order to provide better symptom relief in patients who were unresponsive to lower doses. Both Dynamed Plus and Essentials Evidence Plus list diuretics as potential treatment for Meniere's disease. However, Dynamed Plus states that their strong evidence for efficacy is lacking for the use of diuretics in Meniere's. Using diuretics, you must be careful not to restrict the patient's sodium intake too much. Also, they'll require frequent monitoring of their electrolyte panel. Also, diuretics may have adverse effects, especially in the elderly, so you have to be really careful when prescribing to the elderly. The other medications both guidelines talked about were vestibular suppressants with anti-nausea effects, such as Zofran and Compazine. Hearing loss, dexamethasone, either orally or intratympanically, can be used. Dexamethasone is also used for vertigo that's not affected by lifestyle changes or other medications. There are also surgical options that are used for severe Meniere's: endolymphic sac surgery for patients with disabling vertigo, a minute device for positive pressure therapy to help with vertigo, ventilation tube placement and a surgical labyrinthectomy are options for severe veneers as well. There can also be vestibular ablation where they use intratympanic gentamicin to help relieve the symptoms of the veneers. The nurse practitioner should also consider referral to an audiologist for hearing aids or cochlear implants to improve hearing loss caused by Meniere's disease. And these are my references, my prescriptions.